All right, welcome everybody. Thank you all for joining. My name is Steve Flynn. I lead our customer success and customer support teams here at SurgeLogs. We still have some people coming in through the waiting room here, so we'll give it a couple minutes before we get started. But thank you for taking time out of your day to join us. We're really excited about today's topic, and we have a great guest speaker here. While we're waiting, I'm going to just ask everyone to, if you can, just let us know where you're calling in from in the chat over here on the right. So I'll put the first message in here. We'd love to know where everyone's joining us from. And then also, if you have questions throughout the presentation today, we're going to try to save our questions for the very end. If there's a question in there that's maybe relevant to the current topic or current slide we're on, I might jump in and just ask that question, but we're going to try to hold questions until the end there. And today's webinar is getting recorded. So if you have colleagues who weren't able to make it today, we will be sending the recording out later. Let's see where we've got people joining us from. All right, Kathy, good to see you again from Maryland. Matthew from Pennsylvania. Got Verlene from Arizona. Hi, Verlene. I'll let Savannah know you joined, Verlene. Thanks for joining us. And then we got Amy from Minnesota. Amanda from Austin, Texas. Jordan from Hawaii as well. Awesome. Cool. And before we get started, I can see there is a raised hand from Pana Taylor. So you are going to be automatically muted when you first join, but Pana, if you have a question, you'll just have to, if you want to write it in the chat or if you unmute yourself real quick, happy to answer any questions before we get started. Okay. No questions from the group yet. Okay. And it seems like the waiting room's died down a little bit. I think we've got a great group here. So I'm going to go ahead and get started. So today's topic is, are you leading your ASC or just managing it? So we're joined today by Sandy Berreth. We're very fortunate to have her here. Sandy has 48 years experience in healthcare, 25 in the ASC administration role. She has a master's degree in organizational leadership from the University of Mary, and she has a thorough understanding of federal regulation, is an active AAHC surveyor and educator. So we're really excited to have her here today. Very fortunate. So Sandy, thank you for donating your time. Next is we'll go over kind of like our learning objectives today. So the goal of today's call is to describe leadership techniques that will successfully create future leaders, and then understand how to effectively manage an ASC and how to identify top priority areas needing immediate action. Now we, on the registration page, we polled everyone and asked, how much formal leadership training have you received before you took on or when you took on your current role? And pretty overwhelmingly, the answers were either none at all or some but not a lot. Very few of you responded with, yes, I've gone through a formal leadership program. So that's why when I had a chance to speak with Sandy and she brought up this topic, it definitely resonated with me, and I think it obviously is resonating with a lot of you as well. So I'm really excited to dive in today. Just to kick things off, I love this quote from Vince Lombardi of leaders are not born, leaders are made, and they are made just like anything else through hard work. So that's you joining us here today is the first step towards that hard work. So thank you for joining. And without much further ado, I will hand it over to you, Sandy.
Thanks, Steve. I noticed some of your names on there, and some of you know me personally, and I have to say thank you for the support. It's fascinating that I see people that I know. Verlene from Arizona, number one. I saw Angie from Minnesota, Fargo, North Dakota. So it's so exciting to see people that I know. We're going to start really with leadership. And one of the things I think is probably one of One of the reasons that I want to talk to you is that, just like Vince Lombardi said, leaders are hardworking individuals. One of the key things a leader has to do is they have to be the link. As a leader, your staff look up to you. They look up to you for focus, direction, and they look at your work ethic. When you manage, you tend to just do the work. When you lead with focus and direction. There are keys that all of you, especially if you know me, know that I have, because you've all heard me talk about it. But you begin with the end in mind. Start with a clear understanding of your destination. Start with what you want to accomplish. It can be in 1 hour. It can be in 1 day. It can be in 5 years. But find that focus. Find out where you want to be. Know where you're going so that you better understand where you are and what steps you need to take to be successful. The keys of leadership is quite simple if you look at what you want to see in a leader. I want you to all remember the leader you most appreciated. Whether it's a mentor to you, or maybe not to you personally, but you saw them mentoring others. What attributes did those persons have that met your needs when you watched them? Each of us looks to our leaders differently. Some of us need leaders to be in control, to basically say, this is what I want you to do. Others wait for their leaders to see what sides they are and then invest in what they're invested in. So I'll give you a little story that I've had since I started. Back 25 years ago, when I first went into ambulatory, I had that mentor. I had a nurse manager who took care of me. And what I did was I wanted to emulate everything that she did. So my prime objective was to let my staff know that they were number one in my world, and that staff and family always came first. Remember the saying, one of the best compliments you can receive is having someone imitate your behavior. This behavior isn't just some quirky human trait. It's a fundamental aspect of how we learn, how we socialize, how we navigate the complex world that we live in. Understanding why we imitate others can shed light on everything from social dynamics to cultural beliefs and evolution. It is a window into the very essence of what makes us human, of what makes us us. So I want you all just to take one moment, because that's about all the time we have, and ask yourself, what kind of leader do you most appreciate? And I want you, not now, but to take time afterwards, and I want you to write the attributes of that leader. Think of everything that you admire about that person. Write them down. Here are a couple things that I can tell you that I did. Get to know your team. You don't have to be friends, but you have to identify their interests. You have to show appreciation. You have to be able to let the people that you work with know that you're working with them, that they're not working for you. Send the message to your people that you work with. Send that message that we're working together for a greater goal. If you're a nurse or a business person, watch care. Watch what's happening in your surgery centers or in your area, your space. Watch it. If someone needs help, help them. Business people a lot of times go, well, I can't help in patient care. Yes, you can. You can empty garbages. You can help get a sheet when somebody is cleaning a cart. you can help. And when your team sees that help, sees you pitch in, they know that you're there for them. Everyone wants to feel valued and respected. Discover what your staff want and lead them to that end. Leadership and administrative roles, uh, we can't just manage when we lead, a group of people. Leadership in an ASC encompasses overseeing all of the clinical and often business operations. Us nurses out there know that we don't think like business people do. That is a learned behavior for us. And so you need to be able to do that. While doing this, it effectively manages what you're doing. It provides optimal patient care. It means that you're looking at your regulations and what do I have to do every day? These are the responsibilities that your organization feels that you must have. You need to develop goals and objectives to get there. So from this point, we're going to be discussing the effectiveness and what is important to you as a leader in the ASC community. I want to start with just a second. I want to start with just asking you a second. Does anyone have questions now? This is a huge piece of information because this really is what leadership is versus management. Leadership has many Oh, I'm sorry, Steve.
Oh, that's okay. I was going to say, if anyone can't come off mute or anything, feel free to use the chat feature to ask those questions too, and I'll keep an eye on the chat window here. So if you have any, feel free to use that.
Thanks, Steve. Leadership has many identities, and it's up to you to discover what those are. So let's start. What does a leader do every day when you have to manage an ASC? You have to learn how to do an analysis of your staff. It's important to know, do I have enough staff? Is there a reason that Susie over in the corner is complaining because she's working too hard? And by doing the work, you discover if that's true. You must develop a functional understanding of capital and operational budgeting. This is not easy, especially for a nurse. I'm a nurse. I've looked at the business aspects for a very, very long time. And it took me a long time to kind of get what people were saying to me when they would say something like, you're spending too much money, Sandy. And I'd say, it's money I got to spend. What do you mean I'm spending too much money? The only way that we learn is by learning. And we have to listen to our accountants. We have to listen to the business people that we work with, and maybe the business people we even work for. Remember, your business operation, your return on investment, your staffing productivities, all enhance patient safety through a return on investment. And you need to look at that. What are some of our topics of importance? So I'm going to kind of go through them, and I'm not going to go through them like I would as a AAAHC surveyor. I'm going to go through them for the identity of what's important. So governance, probably number one. A lot of times nobody tells you when you're going to be leading an ASC that governance is probably one of the things that you're going to have the most trouble maneuvering. Effective governance in an ASC setting includes understanding the board structure, knowing how the board is affected by regulatory compliance. You have to be able to review in front of the board what you're doing. Sometimes you have to come up with reasons why you're doing it. You have to get their approval. And every time you're at your board meeting minutes, remember those minutes are telling a story. You don't have to write a lot. You can do it quite easily, but you have to tell the story. And then it's really important that those little details that you discuss maybe aren't in the minutes, but they're somewhere so that you could always refer back to them. One of the things that I used to do when I was in your positions is every time a board member sent me an email or they dropped a note off, I would do a sheet protector. All of you who know me know I love my sheet protectors. I would do a sheet protector with that particular communication, and then how did I deal with that particular communication? And you have to remember that you have to report to the board everything you do. Probably number 2 is licensure, accreditation, and certification. It's important to remember that every state is just a little bit different, and it is something you have to consider. So right now I live in California. Most of us think, oh my gosh, California is really ridiculous. It is no more ridiculous than Arizona or Texas or Oregon or any of the states out east. Find out what those are, look up your state statutes, read your state statutes, and make sure that you are within your state statutes. I will call out to the accrediting organizations. AO is now what they're called. Isn't that amazing? AO. Why do we always put everything down to abbreviations? Anyway, there are several of them out there. If you kind of can go through them in your head, there's the Joint Commission, there's Quad A, there's Triple AHC, there's ACHC. There might be a few that I haven't named, but those are the big 4. And most of you and most of your payers are now expecting you to have an accreditation, not just CMS any longer. I can go in an hour. I can go an hour on just accreditation, but we're not going there. There are a lot of certificates that are now available. For instance, you can get ortho excellence, you can get spine excellence, you can do those certificates. Probably one of my biggest things that I look at and have always looked at is human resources and employment law. Human resources, HR, and employment law and an ASC encompasses regulation and statutes governing the relationship between the employers and the employees. Compliance with employment law ensures fair treatment of employees, adherence to legal standards, and protection against potential liabilities for the ASC. Do we want to take Barbara's question? She has her hand up.
Yeah, sure. Barbara, if you can come off mute, or feel free to use the chat feature too.
Sorry, my apologies. You all froze, and I didn't know if that was across the board or just on my side, but you were frozen for a little bit.
Oh, no worries.
It's fine now. Yeah, sorry about that.
Yeah, no worries.
Oh, no worries, Barb. So now we're just going to go to the next slide. It's staff recruitment, retention, and development. So we've talked about HR, and if you're in a huge organization, HR is taken over by that organization. They usually have an HR department, and we pretty much do what they ask us to do. It doesn't mean we do it necessarily always willingly, but we do what they ask us to do. When you're an ASC by yourself, you're the HR person. And some of the most important thing for HR is staff recruitment, retention, and development. Staff have expectations, especially if they've worked in a hospital previously. And so that staff recruitment used to be, if you all remember the good old days, most of you are probably too young to remember the good old days, but the good old days, all we had to say was, you just have to work days, no weekends, no holidays. Now, the hospitals are offering that. So recruitment is not as easy as it used to be. Retention is even more difficult, as our wages vary. We are going to see everyone maybe go a different route, and in a year they may come back. you may never see them again. Remember that it is a process. You need to attract and hire qualified individuals. And if you're with an AO, you need to be able to prove that they're qualified individuals. You need to implement strategies to retain your staff. That can be, depending on what your staff enjoys doing, it may be a Friday pizza party every Friday. Maybe they like to be fed. It may be incentives that your board is willing to at least discuss. For instance, if they do really well in distributions one quarter, maybe the next quarter they are willing to give the staff a bonus. There are a lot of methodologies that you can come up with to retain your staff. One of the most important things you can do to retain your staff is what we talked about in the very beginning. Staff want to know that you're on their side. They want to know that you will go to bat for them. They want to know that you care. Again, you don't have to be friends with your staff, but you have to let them know that they are thought about all the time. We have to provide opportunities for professional growth and skill enhancement to ensure competent and motivated staffs. One of the ways that I have found that this works really, really well is becoming a provider for one of the state education units. For instance, the state of California is pretty good. If you do an application, you can get CE credits from the state of California. Yes, you have to dot your I's and cross your T's, but that's available, which means that your staff, when you present continuing ed to them, as long as you do a few things that the state board wants you to do, you can get credit, and they can use those towards licensure. One of the most successful things that I used to do as an administrator and as a leader is I did an annual education day. I've tried it all different ways, but I have to say that I used to try to make it fun. I used to try to make it like they're going to a conference. We used to have breakfast, and then we'd have lunch, and then we'd have snacks, and we'd have breaks. At least 6 continuing education units were considered, and we'd always do our competencies at that time, because competencies, again, for your accrediting organization is very important. And so that's something that's just really something you want to think about. Now we're going to get a little bit more technical. Credentialing, privileging, and peer review. A lot of folks have a lot of questions about credentialing, privileging, and peer review. And I think one of the things that we tend to do is we make it harder than it has to be, especially if you're in an ASC that doesn't have corporate backing. You're the one doing that credentialing, privileging, and people think, oh, it's so hard. What you do is you simply look at what your accrediting organization expects you to have, and then just do that. Don't do more. Don't go to the nth degree. Just maintain what your AO asks you to maintain. Your delineation of privileges is so very important. So if a physician decides they're going to start doing something new, for instance, you want to make sure that they have dotted their I's and crossed their T's, they have education, and that you have granted them privileges. Even if it's in the middle of a credentialing cycle, you want to make sure that they are granted privileges for that and that they don't need proctoring. even though that sounds all kind of hospital-based, it's still very important for your accrediting organizations and for wonderful Medicare, Medicaid services, which we know as CMS. Lastly, I want to talk about what peer review is all about. It is an expectation of all of the accrediting organizations as well as CMS that peer review is done. Why is it done? It's done to evaluate and to improve your provider's performance in your ASC. Now, many of us just do chart reviews. We take 5 charts, we hand it to a partner, and we say, I need you to review this chart with 1, 2, 3, 4, 5 qualities and sign your name and be done. And do all 5 of them in 15 minutes because they hate doing them. That's not peer review. Peer review shows our quality of care that that provider is giving. Now, it's not just by looking at their records that everyone knows how to do, especially if you're on an EMR. The doc, I mean, practically fed what they need to do. So one of the things that is most important is develop meaningful criteria for peer review, i.e., have they had any complications? Tell us about your complications. If there is a complication, was it peer reviewed by another physician who is equally licensed and or in the same specialty? What about infections? What about their behavior towards their patients? What about their behavior towards your staff? That's all really important. Together with these processes, we contribute to the high standard of care, safety, and quality. And that's one of the most important things that we do. That's what most of us would say our whole objective is to provide safe, quality care within our ASC. So that goes right into quality management. Many of you are probably challenged with quality management. I don't know if a lot of you are on like listservs that do questions or ask questions, and then somebody somebody will give you resources. I don't know how many times I read, gee, what are you doing for quality? What are you doing for your quality studies? How can you come up with something for quality studies? Quality management in ASC utilizes a systematic approach to ensure the improvement of our safe, effective care. It needs to be patient-centered. And so asking others what they do, it's fine to get ideas, but basically, it's when you find a problem, define that problem. Find out why there's a gap in the processes or the behaviors, and then tell me how you're going to improve it. So, for instance, when we look at our ASC in general, we have patient satisfaction. This is a really easy one. One of the big ones in patient satisfaction, especially for organizations that are really busy, GI, pain management, ophthalmology, we turn over patients really quickly, but there's sometimes when a doc is doing a case and by darn, he has problems, right? He decides that now instead of taking me 20 minutes to do this GI case, it's now going to take me an hour and a half to do this GI case. Or an ophthalmologist discovers that the lens is too hard and he has to employ some methods that are a little bit more difficult, which takes more time than that 12 minutes. It's now going to take 25 minutes. What does that leave us with? It leaves us with patients who are waiting. So we identify that through our patient satisfaction. And it's really, really important that when you identify that, you correct it. You try to find methodologies. That means you're going to make a difference. You're going to change. And that's what quality is all about. It's not the big stuff that you see people suggesting. It's the little things that affect patient care. Maybe it's something that you realize that your staff does. A few years ago, I was in a surgery center and I thought this was one of the best quality studies I've ever heard of. And I was so impressed because it was a young nurse who came up with this. And I tell everybody because I just thought it was so good. And it really was patient focused. They realized in a GI center that did about 20 cases per day per doctor, and the doc would work all day long. They realized that cases in the afternoon didn't have as many specimens as cases in the morning did. And they thought, if that was odd, and why would that be odd? Anyway, they did a study. They collected some data to see, sure enough, they collected like 20%. I don't remember the amount, but 20% less specimens in the afternoon. They came up with one great solution. We are going to stop everything and we are going to make our endoscopists take lunch. They did that. They provided lunch every day for the endoscopists. They scheduled such that the doc had at least 30 minutes, if not 45 minutes, just to rest. They found after an applicable period of time, they found that, now we do have the same amount of specimens. Specimens in the morning equaled the specimens in the afternoon, indicating that indeed their docs were just getting tired and maybe weren't being as effective when they were doing their colonoscopies. And so they made that into a quality study. I just thought it was wonderful that they actually looked like that. So look at what you're doing every day. Don't try to make it a fantastic. Just look at what you're doing every day. Discover the gaps. Look at your care. Look at where your docs want you to be. It's just really important to do that. Now, all of you are with AOs, and most of the AOs have a kind of a standard, a template for your quality studies. That's okay. But remember, you're patient-centric. And so you want to take what's happening to the patient and how does that affect your staff? And you want to combine the two into a quality study. I hope that makes sense for everybody. I could probably spend an hour just doing quality management. This is my favorite topic of everything. Risk management is one of my favorite chapters in the surveys that I do, and I think it is so important. And I think it's something that we often miss because we are too busy to think about it. Risk management in ASC requires a systematic approach for identifying, mitigating, and managing all types of risk exposures. Sometimes we don't even think about the risks that we come across in a day. We think about the big ones. Oh, what if a patient falls? Or, oh, what if a patient is burned? Or, oh, what if we have to transfer the patient because of their low oxygen saturations? Yes, those are the big ones, but I want you to look at the little ones as well, and I want you to practice them. I want you to practice what happens if one of your physician walks in complaining of chest pain. I want you to practice what if one of the nurses comes in and appears to have imbibed too much during the night before and maybe still has alcohol on her breath, his or her breath. I want you to practice those kinds of things. I want you to practice not just medical emergencies such as lidocaine toxicity or a CPR drill. I want you to practice the things that you don't think about. What happens right now? All of you are sitting, of course, at desks, I'm thinking, or maybe you're in a classroom of some sort, but I want you to think about what if the roof just fell in on you because a water pipe had broken, and now you're covered in dust, wet, what would you do? And how would you need to respond? That's a practice drill. That's an internal emergency drill. That is part of risk management. What if I have to close the surgery center tomorrow? What am I going to do? The other thing I think you have to be really conscious of is safety. Much of what we're going to in our future seems to be around the active shooters, people who can walk into our surgery center and hurt other people. What kind of security measures do you have to prevent that from happening? So I've often said to small surgery centers that have a receptionist at the front desk, whatever you call them, whether they're patient care coordinators or whatever you call them, they're the person that chances are they will get hurt. And it's really important that your staff isn't running towards the danger and that they're running away from the danger. Even though they all love that receptionist, that might be something we have to come to later. You have to learn how to identify those emotions, not just, kind of the rules and the technical part that police officers, fire officers tell us about. We have to remember that all of this has emotions attached to it. And it's important to be able to identify those and discover them. Risk management is a culture of safety, and it's essential for the applicable operations and strategic plan. I hope that makes sense to y'all. Next is medical management, medical record management. Many of you probably have EMRs, and so you think, how does this affect me? But it does. Even an EMR must be maintained. It must be handled securely. You have to remember that even though you have an EMR, and the majority of the time you check, right? But sometimes you still have to make a note. Sometimes you still have to say what happened. It's part of risk management. It's part of quality management. Your medical records, if you're on an EMR, need to be looked at just as critically as paper records. The beauty of paper records is I can change them at the drop of a hat, educate my staff, and move on. With an EMR, you have to go through IT. You have to make adjustments to IT. And that sometimes can lead to a lot of frustration on your clinician's parts and also your surgeon's parts. One of the things that I will tell you that I've had the most problem with when you're either on an EMR or you're on paper and anesthesia doesn't like the way you're doing it. That's okay. Just make sure, again, go back to your AO, go back to your standards, look at what the expectation of anesthesia's records are all about, and make sure that what the record they want to use has all of those various criteria on them. One of the things we forget about is when we're doing RN sedation, i.e. conscious sedation, RN, that RN is involved. Remember that your clinician, your provider, has to provide some of those anesthesia type standards that are written. And when a surgeon says, well, I'm not going to do that, somebody's got to do it. And if you don't have anesthesia, somebody's got to do it. Your nurse can do it. She's qualified to do it. One of the things you want to make sure that your nurse that's qualified also has competencies that says she's qualified. And you, as their leader or as the manager, you can't define those competencies. Those competencies are defined by a physician. And the physician is the one that also should be doing an evaluation on that competency of that nurse giving moderate sedation. Whoops. Sorry, everybody. Let's go back to life safety, emergency preparedness. Life safety and emergency preparedness in an ASC involves implementing measures and protocols to safeguard the well-being of patients, staff, visitors during unforeseen events. I will tell you right now, life safety is probably one of the biggest issues in our ASC world right now. Most of us have a fire marshal walk in on an annual basis. He may or he may not do a critical look at your processes. And generally, you get a certificate from the fire marshal that says you're A-OK. Then another year goes by, and now it's ready for reaccreditation from your accrediting organization. And you decide to do deemed status because you don't want CMS to walk in anymore. And the life safety person comes in and says, wow, what a mess. You need to have a type 1 because you have general anesthesia, and you have a type 2, you have a type 3, and you all are thinking, what is he talking about? The key to life safety is learning life safety. There are a lot of people out there that are willing to help you learn all about life safety. Life safety is not difficult. It is dotting I's and crossing T's. It's about the details. I do have resources, so if you do want a couple good resources, I'm happy to share that with any of you online. Again, life safety would take me a couple hours, and I'm not even an expert at it. I know enough probably to tell you all that you're in trouble, or if you're not in trouble. A couple things that you can do real quick with life safety is make sure your exit signs are all lit. Make sure your emergency lights are being checked on a monthly basis for 30 seconds. And at the end of the year, they're being checked for 90 minutes. Make sure that when you're checking your generator, if you have a generator, you want to make sure that the generator is being properly maintained. You may want the generator company to do it. Or you may want one of your staff to be trained. You may want a facility guy from the hospital to come in if you can get them to do it on a contracted base. But you want somebody who understands. Remember, your sprinkler system has to be checked on a quarterly basis. Remember, every time you do a fire drill, you need to make sure that the alarm is set off. There's a million little things that we all need to know, and nobody seems to want to train us to do that. And so I'm happy to give you some cheat sheets, always happy to take emails as well. I'm going to spend just a minute on emergency preparedness. A lot of people are confused on what you need, what kind of drills you need to have. And so I'm going to spend 1 minute on that. This is something that you as the leader need to manage. You need to know if you are doing it the way CMS wants you to do it. At this point, your accrediting organizations are second and Medicare is first. They expect you to have 4 fire drills. 4 fire drills have to be quarterly. Now, I will tell you that I was at a surgery center not too long ago down in Texas, and they do have a homeless population, unhoused population, and they had a fire in their dumpster, and they used that as one of their fire drills. I thought it was unique. Again, use external as well as internal opportunities to write up your drills. One of the things that must happen is you must pull that fire alarm. Now, usually your alarm company asks you to let them know. They don't look kindly upon somebody just going and pulling an alarm. I did that once. I didn't mean to do it. I did kind of mean to do it, but I did that once. And everybody gets really upset about it, especially the fire guys get really upset about it. But you know what? I found and discovered that our processes weren't as good as we thought they were, and it worked. And I only have done it once. I promised that I would never do it again to the fire guys that came to my door in their big red truck. I promised I would never, ever do it again, and I've never done it since. So I promise I will not come into your center and pull the fire alarm. I may pull your code alarm, but I won't pull your fire alarm. So that leaves us with our internal and external emergency drills. I will tell you that you need to do a CPR drill because CMS says you must. And if you are contracted with CMS, you must do a CPR drill. If you have general anesthesia, or if you have inhalation gases, if you have, triggering agents for MH, you must do an MH drill on an annual basis. Again, one of the things that I like to do is tell anesthesia, ask them to help you with that. Another one I just recently heard about was your lipids. Train on lipids. I would say that the most important surgery centers out there that need to train on lipids are your plastic surgery centers, because lidocaine toxicity is fatal. And you want to learn the symptoms and the signs that you might be having some problems. So you want to train on lipid toxicity. Lastly, make sure that your external drills have something to do with your community. A tornado is a great one. Earthquake is a great one. So everybody here in California, if you feel those little tremors, go ahead and make it a big tremor and make it a big deal. California, the state of California, the state of Arizona, both have what they call the Great Earthquake. We call it the Great California Shakeup. And that really comes in as well as the state does a really good job. They send you everything you need. I have said to organizations all over the country, because earthquakes are becoming more and more an identity in many, many places. Call California. Find out what they're doing. See what kind of resources they're using. That's a community drill, and that will work. Remember, your internal drills you can find a million of them. Whenever anything bad happens, I had a patient when I was up in Minnesota. They fell outside on ice, and I considered it an emergency disaster, because it was in the middle of a blizzard and no one should have been out, except of course my docs always worked in their blizzards. And so you want to use that. Ice storms are popular in the middle part of the United States. Look at ice storms, things that just happen and they occur naturally. Now, do we have an ice storm in the middle of summer? No, you have to come up with something in the middle of the summer. If you don't live by the water, don't do a tsunami. If you don't live in Tornado Alley, don't do a tornado. Find things that are practical for your location. Delivery of patient care. Patient care in an ASC includes activities from pre-admission through discharge, and you need to have policies that talk about that. And then the key is you need to have people actually follow those policies. One of the things I always tell people is don't write a policy and expect a nurse to follow it unless it's her practice. Look at what your practice of your staff is and then write the policy. Make it something that they identify with and that they know how to do. One of the things I've long since stopped doing is writing a procedure for starting an IV. I would bet I can see that there's 14 or 15 of you on right now. I don't know how many of you are nurses. But of you nurses, I bet all of you have just a little bit different technique for starting an IV. One of the sure shooting ways to have CMS come down on you is by them watching someone start an IV, going to your policy, and it doesn't match. So don't kind of where they say, don't sweat the details, don't sweat the details. Tell me that an IV is going to be started aseptically and that you are going to monitor that IV site. And if there's any problems, redness, or something that you notice, you're going to remove the IV and you're going to make sure the catheter is intact. Be very generalized on those kinds of procedures. And that anytime you get specific with a procedure, you run the risk of not doing it the correct way. The planning for high quality perioperative of care, it really does involve everybody. It involves anesthesia, it involves your radiology, it involves lab. Most of you, I'm sure, do HST, and also, I'm sorry, okay, everybody, rewind. You do HCGs, and you do probably glucose. And so those are some of the things that we do. You need a CLIA waiver for that. Make sure you have your CLIA waiver. And make sure that the laboratory director on your CLIA waiver is qualified to be a laboratory director, because that's become a big thing with the Centers of Medicare and Medicaid Services. So make sure that you're doing that properly. A lot of you probably don't use lasers. A lot of you may use lasers. Remember, you have to have a laser officer. You have to have a safety officer. You should have a risk management, a risk manager. It's surprising all the caps that you as administrators wear. Most of the time, you're the ones that are wearing all of those caps. You're the safety manager. You are the safety officer, the risk manager, the laser officer. You're it, and so you have a huge piece of the pie that you're responsible for. I want to touch on medical management just a little bit. It is not just making sure that you have the appropriate meds that your doctors want. You have to make sure that you are following all the processes that the DEA says for narcotics, for instance. You have to make sure that you've got a look-alike, sound-alike list. You want to make sure your look-alike, sound-alike list is actually what you have at your organization. For instance, if you don't have ephedrine, don't say that that's a look-alike, sound-alike. Most of you that do general anesthesia, of course, you have ephedrine, and so ephedrine is one of our favorites that we use all the time. You also want to use, one of the things that I've found and I think is really important are your high-risk meds. Those change, so you want to check that on an annual basis. The other thing you want to remember is that all narcotics are considered high-risk all narcotics are considered high-risk meds. And so on the outside of your medication locker, or however you have it secured, you want to make sure that you put a label that says all narcotics are considered high-risk medication, and we will treat that as such, whatever your policy is. And I just wanted to mention that. Remember that you have to do annual training on medication and on your higher acuity. It really is about ensuring patient safety and compliance, and we have to safeguard against errors, abuse, and diversion. Accounting and finances, I'm going to briefly talk about it because a lot of you probably aren't really in tune with your accounting and finances. That's those small surgery centers out there. And that's just a system on how best practice is captured financially. And it involves assessing operational costs, monitoring revenue streams, and budgeting, which for us nurses is a little difficult. And that goes right into revenue cycle management. Remember that the processes and the policies for billing, coding, auditing, and collections are done either by you or they're outsourced. Ask questions. Make sure that you are are asking questions of your billing people. Don't just accept what they say as fact. Make sure that you start looking at your fee schedules before you start talking about contracting, and all of that's part of it. Supply chain management, that again has to do with a systematic coordination and oversight of all the processes about getting the proper storage. And I think one of the hardest things that we do is just do that, right? We have to find a person. It doesn't have to be a nurse. It doesn't have to be it's somebody that you identify that has a passion for supplies and has that detail-oriented part in their heart and in their head of what you actually need and what you don't need, and that they're able to work together not only with you, but that they're able to work together with everybody in the surgery center, including your physicians. Creating a culture of communication is really what it's all about. A culture is a set of shared values. Discover what your staff want. The culture meaning rendered some behaviors as normal. They might not be normal normally, but they're normal for your staff. There are rights and wrongs and strange behaviors. The key to building culture is communication, and it's to develop an understanding and respect and differences for each individual.
I was going to ask Sandy, if we go back to the previous slide real quick.
Culture?
Yeah, something I've definitely heard as well is definitely you want to create a blameless culture as well. So this kind of relates back to safety and that adverse event reporting, is that if you have a culture of blame, people are hesitant to maybe like raise their voices or to point out those near misses. So when you have a culture of safety, where that's always the forefront in everyone's minds, it encourages people to speak up. So as leaders, would you say it's like incumbent upon us to create that culture?
It is. It's difficult because nurses blame anyway, and so to have a culture of blamelessness, that's really difficult for nurses, and so it's something that you talk about. I'm going to point out the state of Minnesota has a great program, and of course now I want to say it and I can't remember the name of it, but it's a culture of safety, or somebody from Minnesota. What's the culture of, whatever it is. Anyway, I wish I could remember. I'm just old. But one of the things, I think you're right. I want someone to tell me if an error has been made. One of the reasons I do a variance report instead of an incident report. If there's a variance to practice, I want to know about it. Good, bad, indifferent. If it's good, I get to say thank you. If it's bad, I get to say oops. And we find ways to correct it. So you're absolutely right.
Is it a culture of full disclosure? Is that what you're?
Actually, Verlene just said culture of safety. Though it really, I wish I could remember it.
You, Sandy, is that USPI supports us, and we have like a little program where we go over it annually, the culture of safety, making people understand that it's okay to share, to stop the line, to
Exactly.
share any information that we can learn from, no matter if it's against about a physician, a staff member, whatever it is, that we're all in this together and that we'll learn from it.
Absolutely.
And it works.
And I would say that to everybody, right? Everybody out there, the more open communication you have with your staff, the more you learn. The more you learn, the more you can lead the staff that you have there. And you're absolutely right. I do an annual kind of workshop for my staff on that kind of a philosophy. And I do think it's important. Why do we listen? we admire and believe because they are experts in what they do. Our leaders have credibility. If they don't have credibility, we're going to learn about it real quick. And we listen to staff because they have credibility. They're doing the work. Leaders, listen to your people. Even if it's complete, even if they're just complaining, listen, take something from them. Learn that they're trying to tell you. They may not know how, but they're trying to tell you. And every person in your ASC has earned the right to be listened to. It's just something that I believe. And so really, that's kind of it. I'm sorry if I went over a little bit.
No, that's fine. Sandy, thank you so much.
You're very welcome.
I think we covered a lot of topics here. Oh, great. Thanks, Barbara. So yeah, I'm going to open it up to questions now. I want to be conscious of everyone's time, but if there are any questions, feel free to come off mute, use that chat feature to type them in. As I was listening to everything, I was going to say, we were mentioning credentialing and licensure, competencies in education, tracking and recording all those board meeting minutes, the risk management drills. If you are a SurgeLogs customer, you know that we can provide a tool or platform to keep track of all of those things, and even the competencies as well. That's something we're stepping into. And then just to touch on the 4 major AOs, accrediting organizations, we have partnership agreements in place with all those major accrediting bodies now, so that their standards that you're held accountable to are stored directly within the app. And we have a policy and procedure management tool that allows you to store those policies, collect or submit them for annual review, collect those signatures and acknowledgement from your governing board. So if it's been a while, maybe since you've checked out SurgeLogs, please go to our website. If you're a current customer, please reach out to us if you'd like to hear more about that. Looks like a couple questions came through.
I do want to say one thing. I was talking about variance reports, and somebody just asked the question, is it HHC CMS compliant? It is, if you say it is. Remember, your variance reports are by policy, and in that policy, you're going to talk about incident reports and adverse reports, and so it then follows your standards because it's part of policy. The real reason we use variance reports is because we don't want it to be we don't want people to be afraid to do that. We just want to know what's out there. So yeah.
And then just kind of quickly sharing our website again, if you just go to surgelogs.com, this is all available. So if you're a current customer and haven't seen it yet, we definitely encourage you to check out some of the newer solutions like standards and policies. Keeping track of staff licensure and credentials are all things we deal with every day. All those drills for risk management definitely live under this the logging portion as well. So if you're looking for a solution or a way to just manage all these things we just covered a little bit more easily, please reach out to us or visit surgelogs.com. And then can you discuss? Oh, looks like there's another question in there. Stand by. Just have to switch my window.
Hi, this is Barbara. That's my question as well. So we're a current customer of SurgeLogs, and we are just starting. We're a fairly new customer. We love the logging and document storage. We're kind of tackling that first, and we're about to dive into the policies. So I wanted to ask Sandy, you had mentioned crafting your policies around how things are done in your center rather than the other way around. So as we're going to be starting our policy review and updating in December, how would you recommend we approach, since there are template policies and they are compliant with the standards? We want to start with those and then make small changes based on our type of cases, our facility environment, all of those kinds of things. But can you talk a little bit more about writing the policy from how you do it versus you know, starting with the staff processes and standards first rather than the other way around.
I don't know what you do at your facility. I'm going to use eye drops as an instance, whether you do ophthalmology. I'm sure there are some people on that do ophthalmology, but I will tell you that everybody does an eye drop a little bit differently. And so what I did before I had a template for an eye drop. I knew how to give an eye drop. I knew what they said in the standards, how to give an eye drop. But I still watched my staff give an eye drop so that I knew what they were doing. And if I saw that they were maybe touching the eye wrong or something, I had the opportunity at that point to say, you know, maybe we need an in-service. And that's when you develop the policy that you want to work and you talk about that in-service. And I will tell you, it's a great quality study because you've identified a problem. What's the gap? And now you're going to tell me how you're going to fix it through a policy. I will tell you that probably one question that I get the most often from people when I'm just kind of hanging around is, can you look at my policies? Can you make sure that they're okay for AAAHC? And you're right. Policies are probably one of the toughest things we deal with. Number one, most of us got our policy from a policy book somewhere, and it's way too much. You need policies that relate to what you do. And so you need to look at your practice. You need to talk to your docs. You need to decide what's important for you. And that's really what that's really what policies and procedures are all about. I don't know if that answered your question. If I can answer your question better, please feel free to reach out to me either via email or via a telephone call. I answer texts better than I do emails. But I will tell you that policies are a big thing and they're getting bigger and bigger. I don't know which AO you have, but most of the AOs are very clever and they say, you must have a written policy on. And I went through the manual and I found every written policy I needed to have. And that's kind of how I went about policies. And yeah, what can I say? I do want to say one more thing before anybody else leaves, because, and this was not bought and paid for by Steve. I will have to tell you that whenever I walk into a surgery center that's using surge logs, I would say that 99% of all of their documentation that they need is right there. And I really appreciate it as a surveyor. Now, that's just me. Saying that there's other organizations out there that do something similar, but I can tell you when they say, oh, we're on surge logs, I usually know they have everything. So Steve and Oscar, that's just a sidelight.
Thank you, Sandy. We really appreciate you taking time out of your day. I know you've got a busy schedule with surveys out there. So for you to spend an hour here with us with some of our customers, we really appreciate it. Obviously, we covered a lot today, and we're so thankful for the knowledge you're able to share. This will be available on our website, the recording afterwards. So if you want to watch it back or share it with any colleagues, it'll be available later along with the slides. We'll email those out as well. We host these webinars. We try to do it once a month, once every 2 months as well. So we'll have another one coming up soon. And we always try to invite guests like Sandy in to be our guest speakers. So thank you so much for joining us today. If you do have any questions, feel free to email Sandy. I've got her contact info up on the screen here. You'll get those afterwards as well. But yeah, without anything else, we'll see you on the next one.
Thank you all for being patient and listening.
Thank you, Sandy. Take care.